Good afternoon, everybody, and thank you for joining us on today's webinar, Supporting Mental Health in Older People with Frailty. This webinar will be presented by Mandy Ramley-Bluss, Associate at the Acute and Specialised Care Frailty Networks, and Vicky Tweedy, Advanced Nurse Practitioner in Dementia and Frailty at Dorset County Hospital. Now I'll hand over to you, Mandy, for the introductions.
Okay, thank you. So as Lena has already said, I'm Mandy Ramley-Bluss. I'm an associate with the Acute and Specialist Care Frailty Networks. And over to you, Vicky. Oh, sorry, should have just, let's make sure. There, over to you, Vicky.
Hi there, my name's Vicky Tweedy. I'm a mental health nurse by background, but working in an acute trust outside of psychiatric liaison services. I am currently employed as an advanced nurse practitioner working in dementia and frailty, and I'm the nurse lead for our frailty team.
Thank you. So what we were planning to talk about today is to explore the concept of frailty and mental ill health, see how it can be recognised and assessed, recognise the reasons for potential manifestations during this time of our pandemic of COVID-19, and examine practical ways to recognise and manage it in a person with frailty who has got mental ill health. So we'll move on. Why should we look at mental health? And I think it's really timely that we look at this. Most of the definitions of frailty consider the physical health aspect, rather than considering frailty as a combination of both physical and mental health vulnerabilities. Mental health could be at risk of becoming everyone's problem but no one's responsibility if we don't think about it and implement and expand older people's community teams for older people with severe mental health illnesses. There's been a lot of work done about it, and the Royal College of Psychiatrists just last month said that although not all old people are frail and not all frail people are old, but frailty is often an issue amongst older people suffering with mental health problems. So they actually felt it was really important to define frailty to incorporate mental health. And the Right Care in 2016 said frailty is a distinctive state of health related to the ageing process, usually characterised by a complex mix of physical, mental health and social care needs. It's a condition where the body's inbuilt reserves are eroded, meaning people are vulnerable to sudden changes in their health, triggered by seemingly small events, such as minor infection or a change in medication. And also, the British Geriatric Society said that frailty is a distinctive health state related to ageing process, in which multiple body systems gradually lose their inbuilt reserves. So when we look at that, what are the sort of common mental health conditions that happen as we get old? Well, and anybody, but in frailty and older age, we've got to think about dysthymia, I can never say that word, and distress. And there is an instance of dysthymia and distress, which is a sort of form of subclinical depression. When you're feeling sad, not your usual self, reduced interest in hobbies or activities, and low motivation. Obviously, depression and anxiety are also common amongst all of us, and particularly within this time of a coronavirus pandemic. We mustn't forget our older, frail patients that are often in the shielded population, very isolated at this time, may well be suffering from one of those three things. And then we've got, obviously, dementia, serious mental illness, bipolar affective disorder. So those are the sort of mental health things that we need to consider and think about. We've got to remember that psychiatric illnesses are common amongst older people and associated with increased mortality and other physical comorbidities. And high levels of loneliness were associated with increased risk of becoming physically frail, pre-frail 4 years later. So Gail would have us understand. When we think about mental health and frailty, we've already said they're common. And people with frailty often have a higher prevalence of depressive symptoms. And the other thing that's important to think about is that frailty has been proposed as a risk factor for cognitive decline, mild cognitive impairment, and dementia. And the prevalence of frailty is 32% of patients with mild to moderate Alzheimer's do have frailty present. And it is a significant predictor of all dementias. So if you do have somebody that is frail, then do be aware they could develop dementia. And if you have someone with dementia, do be aware that they could be frail, and think of those two going together. The other thing that, if we think about mental ill health in context of the coronavirus, COVID-19, the Lancet just last month in May said that we must be aware that there might be new onset psychological morbidity and psychological distress, that people with pre-existing psychological conditions may have these aggravated. The distress to caregivers, relatives, and those affected by COVID-19 may also be a reason why we'll see more psychological distress. Not forgetting the effects of quarantine. If people live alone, they're shielded. That at the time of when we all went into lockdown, they were the same effects for everybody. But now that restrictions are lifted, it can be much more isolating with those people who need to feel. And the other thing that has been found post epidemics is that post-traumatic stress disorder does increase, and it can increase by up to 33%. So there's no wonder that there are concerns about this tsunami of mental ill health that might be occurring post the pandemic. JAMA just last month also said, what do we know that does increase during epidemics? And they identified 5 areas that do increase when you have an epidemic: depression and anxiety, post-traumatic stress disorder, domestic violence, alcohol and substance misuse, and child abuse. These all are seen to increase during epidemics, and now we're in a time of a pandemic, and so it wouldn't be surprising if we see more of these areas of problems. And I think it's really important, becomes even more important, that we as healthcare professionals start looking for the manifestations of some of these things in our patients. If we think about in the context of COVID-19, 43% of psychiatrists have seen an increase in urgent emergency cases since the lockdown. And at the same time, they've seen a fall in their most routine appointments, and they themselves are fearing a tsunami of mental illness that's going to arise after the pandemic. They've been alarmed by both the drop-off in routine work, especially in young people's mental health services and old age psychiatry, and by the increase in urgent cases. And so there are places around the country where they've looked at what can they do, given that routine appointments are tailored off. Some mental health services, so I think in Northumbria, they've worked across their system, and what they've been doing is telephone appointments, so that they haven't lost their routine psychiatric ill health population. So they have maintained their telephone conversation. But in many parts of the country, the routine psychiatric work has stopped, and therefore people are becoming more urgent and emergency unwell with their mental ill health, and so are presenting as in urgent and emergency care. Survivors, we've got to remember that those who survive COVID, particularly those who've been in ICU, can often feel very stressed, guilty, and there's a high relationship to post-traumatic stress disorder and depression in the group of people who do survive COVID-19, particularly those that were the more severe type who were in our intensive care units. And mental health consequences are said to last longer and have as great an impact than the actual pandemic, and we can expect to see an increase in suicides. The World Health Organization are really concerned about that, and they published some work in May to talk about that and how we should be mindful that there might be an increase in suicides and be looking for it. The Office for National Statistics in May this year, as they did in May last year, asked the general population and tried to get a feel of how people feel in relation to being worried and anxious. And not surprisingly, 82% of the population of the UK did feel more worried and anxious whereas last year it was only 21% at a similar time. So we can expect to see more anxiety. Indeed, we probably are seeing more anxiety than we were. And the other thing that I listened to a webinar the other day with Dr. Catherine Sykes, who's a psychologist, who's written a wonderful book that's listed in the references. But she said that one of the unique features of a pandemic is that it confronts all our human fears. And there's 3 fears that all humans, however much we think we're not, can experience. It's unique to humanity. And one of those is loss of control. So during times of pandemic, we always fear loss of control, and some of us have a need for control more than others. But during a pandemic, we will feel a loss of control because we aren't able to control what's happening. Equally, social isolation, that however socially introverted we may be, we all want to have some social interaction. And during pandemics, what happens? We get quarantined, we all get sent to be on our own, and therefore social isolation, that is a fear of ours anyway, becomes greater. And equally, the other fear that we have as humans are the fear of death. And here we are in a pandemic with a disease that we know kills people indiscriminately. And therefore, here we are with a unique feature that confronts all 3 of our biggest fears. So she says that we mustn't forget that this pandemic will confront not only our patients, but equally ourselves. And therefore, we mustn't forget healthcare professionals. Those of us that have been involved in the coronavirus disease, the pandemic, are exposed to high levels of stressful or traumatic events and express substantial negative mental health outcomes, including stress-related symptoms and symptoms of depression, anxiety, and insomnia. And what I would say is, never mind our patients, we should be aware of this in our colleagues and try and support each other during this difficult time. If we look back at thinking again about mental ill health and frailty, there's been a number of studies that show there's a bidirectional association between being depressed and frail in later life. And it indicates that frailty and physical health difficulties increase the likelihood of comorbid mental health difficulties. So are we looking for depression in our frailty patients? Are we aware, are we thinking of that? Or are we putting down their perhaps lack of motivation as them being beyond rehabilitation? Do be aware that some of our patients will come across, in fact, many of them may not be openly telling us they're depressed, so we've got to go looking for it and thinking if the more frail they are, the more likely they are to suffer with depression and vice versa. And when participants showed increased levels of frailty in a study by Ukmanovich and Gobbins, they said when there was increased levels of frailty as measured by the TFI scale, there was an increase in the levels of anxiety and depression. With increased anxiety and depression, there was deterioration in the quality of life of patients. Particularly, they were looking at heart failure. And depression is considered an independent risk factor, cardiac-related deaths and cardiac-related incidents, and is a strong predictor of rehospitalisation. And anxiety seems to be an adequate predictor only if it's in conjunction with depression. So anxiety on its own is not a strong predictor of rehospitalisation, but anxiety and depression, and indeed depression, are an independent risk factor for rehospitalisation. And obviously, if you are frail, additional frailty components can worsen outcomes in depression. 39% of people, according to the Soiser study, who are frail are also depressed. So we must think about, here we are, and the World Health Organization clearly stated that older adults, particularly those in isolation and those with cognitive decline or dementia, might become more anxious, angry, stressed, agitated, and withdrawn during this outbreak or while in quarantine. And what we should be doing is providing practical and emotional support through informal networks and health professionals. The other thing we've got to remember is talking about mood and emotions may well be very difficult for older people with frailty. And we've got to take into account cultural and personal history might have an influence on their beliefs about talking about their feelings and actually seeking help. And if we think about in relation to cognitive impairment, neuroimaging studies have shown increase in frailties associated with increase in cortical atrophy, and especially severe global and frontal temporal lobe atrophy. And there is a correlation between frailty and the risk of developing Alzheimer's disease that's independent of any Alzheimer's disease neuropathology burden. So there's an argument that frail people are 8 times more likely to have cognitive impairment. They're 8 times more likely, therefore, to have some kind of dementia, 6 times more likely to have vascular dementia, and 4 times more likely to have Alzheimer's disease. So we should be thinking about this. I think we're getting much better at looking for cognitive impairment and thinking about dementia with our older frail patients, but it's just something to be mindful of. The other thing that we've got to think about is where situations where frailty and dementia coexist, there's a high level of carer burden. Indeed, myself, I cared for my mother with my family with her dementia, and she was extremely frail. And at that time, I was reflecting on this the other day, at that time we had a lot of support from outside. We were linked to lots of support services. But think about the carers at this time who may be increasingly stressed, both concerned about who might be coming in the home and what they might be bringing into the home of their loved one, but equally about being isolated at the moment and isolated indoors with somebody with dementia who might themselves be getting angry and frustrated. So we mustn't forget the carers in all of this. And frailty and pre-frailty, I've already said, have been independently associated with dementia, but actually they've been independently associated with challenging behaviour and the carer burden in dementia. And there's an increasing need for including measurement of frailty and dementia research. So there's some work now being looked at about frailty and dementia, and it's increasingly being seen to sort of work along hand in glove. If we think about the cognitive impairment, it's been suggested, as already talked about, a significant risk factor for dementia, and it's been found. I mean, the other thing, of course, is if you have got somebody who's frail and they're cognitively impaired, there is a significant influence on cost and resource utilisation. And they're just reiterating really how important it is to think about frailty and assessing cognitive and looking for impairment. We think about late life depression. That's defined as a depressive disorder occurring in a patient older than 60, although the onset and definition of cut-off might vary. And it's the most common mental health problem in older adults, and it exerts a profoundly delirious, anyway, it's bad for you, on patients, families and their communities. It leads to significant distress and is associated with several adverse outcomes. For all of those reasons, therefore, we need to be thinking about mental ill health. And we mustn't forget about serious mental illness. People with severe mental illness are at greater risk of poor physical health and experience elevated premature mortality compared with the general population, mostly through the preventable physical causes. But we've got to remember that people with severe mental illness might be more likely to become frail at a much younger age, well, there's not much research done about this. And if we think about this population and think about substance misuse, harmful use of alcohol and dependence, is highly prevalent in those hospitalised with serious mental illness, and it's been increasingly recognised by adults. Mustn't forget about substance misuse and the fact that it is an under-recognised area in which we do need some specific expertise in that. So we know also if you've got excessive alcohol use, dementia, mood disorder, high risk for frailty. So the two go hand in glove. questions. But given that most COVID-19 cases will be identified and treated in healthcare settings by workers with little to no mental health training, it's imperative that assessment and intervention for psychosocial concerns be administered in these settings. And it's really important for those of us without mental health expertise to seek out and work with our mental health colleagues, and equally to be able to do assessments and look for mental ill health in these patients. Is an occupational therapist who does explain that they've become well versed with post-COVID and patients being isolated from their families in hospital, and they themselves in their service have looked at and started doing meaningful activities with their patients. So that's brilliant, Amy. I'm pleased to hear about that. And I've already talked about up in Northumbria and across Newcastle Health Services, they've started doing quite a great deal of work at integrating health and mental health and looking at how each can support each other. And more, we look towards having some more seminars in which they can tell us about what they've been doing. So look out for those. Anyway, over to now to Vicky. So thank you, Vicky.
That's right, thank you. Thank you for having me on the call. I guess one of the biggest parts of my job is to kind of spread the message in an acute hospital that mental health is just as important as physical health. And that's kind of reiterated by the Royal College of Psychiatrists, who said not all elderly patients are frail and not all frail people are old, but frailty is often an issue amongst older people suffering with mental health problems. So again, just reiterating what Mandy's been saying. Next slide, please. So just thinking about delirium, which we see very commonly within the acute hospital, that physical illness or medication side effects are more likely to result in poor mental health and therefore warrants a thorough investigation in every case. So we'll see patients coming in and actually often they'll say, oh, they must have a dementia, this is a progression of dementia, when actually it's something that's treatable and reversible. So every older adult should have a medication review and a targeted physical examination with some basic blood tests to rule out an underlying cause of a reversible confusion. My advice would be, if you need to prescribe antipsychotics in order to treat the levels of distress in a patient who's delirious, then go low and go slow. Back to you, Mandy.
Yeah. So why is it important? And with delirium, it's very important because it's often not diagnosed, and it's a common problem of 15 to 30% of patients affected in acute care any time. Delirium leads to increased length of stay and complications, often poor outcomes, an increase in mortality, and people getting admitted to care homes. And it often takes a long time to get better, and it doesn't always get better. One thing I would say, during COVID, delirium seems to be common, but whereas normally we see a lot of mixed delirium or hyperactive delirium, within COVID the case seems to be that people are suffering more with a hypoactive delirium. So we need to be aware of it and to be looking for it. When people are becoming more sleepy and difficult to rouse, are they actually developing delirium? So I don't know why that's come up twice. So over to you, Vicky, again.
So aside from delirium, we've already heard that depression is one of the most common and most treatable reversible mental illness in old age. It affects 1 in 5 older people living in the community, but this figure doubles in the presence of physical illness and then trebles of patients who are in hospital or care homes. So we really need to be thinking about the patient in front of us, and are they actually depressed? So patients with frailty, we know, have a higher prevalence of depressive symptoms. So the next slide will show you the symptoms, some of the symptoms that you might see. And on the left-hand side of the screen are symptoms that you'll see in all ages of people with depression. But on the right-hand side of the screen are more common symptoms that you might see in older adults, and therefore may be the only presenting symptom that you might see. So difficulties in concentration and memory are common in depression in older people, but making it difficult to rule out a dementia. However, speech and word finding are very suggestive of dementia rather than a depression. So just thinking about your full assessment there. But if in doubt, treat for a depression and investigate for cognitive impairment if symptoms persist over more than 6 weeks of treatment. We're not very good at asking our older patients whether they have any thoughts of suicide or self-harm, and very often these patients will tell you the truth if they ask the right questions. So 1/5 of suicides happen in older people, and the most common form is overdose, most likely because people have much more medication and have the means. So the risk factors for suicide in older people are being male, being widowed, increasing age, social isolation, so definitely something that we should be looking at in COVID times, as well as physical illness, alcohol misuse, which again, we're not very good at asking our older population, and either a past or present depressive illness. Next slide, please, Mandy.
Just before I move on, I was just going to say, for those therapists in the audience, do think about that patient who you think isn't motivated or is complaining of being weak all over. Are they actually, is that the symptoms that's expressed there? Is that a symptom of depression? Are they actually depressed rather than not motivated to get better when they're in hospital? So it's just about considering that. Sorry, Vicky.
Absolutely. No, that's right, absolutely. So anxiety disorders are extremely common in older people. However, it's much less common to see the disorder as a new presentation. So if somebody is exhibiting a new presentation of anxiety, you need to consider what else might be happening here, or whether somebody has indeed got a history of an anxiety disorder. Anxiety can be a presenting feature of dementia, depression, and physical illness, and should always prompt investigations to exclude any underlying medical cause in the same way that we would look for that in delirium. Most common causes of anxiety might be a myocardial infarction, an arrhythmia, thyroid disorders, and also vitamin deficiencies. But on the other hand, symptoms of anxiety can also be mistaken as signs of physical illness. So it really needs careful unpicking of the patient who you suspect is anxious. Back to you, Mandy.
And so what can we do if we to recognise that somebody who we're seeing is anxious or depressed? And it's suggested that we review the DSM-5 codes, diagnostic criteria for late life depression, and we should use screening tools that we're going to talk through to screen, to look for depression in these older, frail groups. Sorry, that was my alarm. I'd set it so that I wouldn't forget to swap over to Vicky, but I'm ahead of myself. As Vicky already talked about the importance of doing a physical examination, ordering lab investigations to really find out if there's any medical problems that might be associated with the depression, as well as just looking for depression. We shouldn't be any more just saying someone's just depressed without equally looking for the physical causes as well. We should be thinking about how severe are they. In a very severe depression, people can be very psychotic. Equally, they can be catatonic. Vicky's already talked about assessing suicide risk, and we shouldn't be scared of asking our older population if they've contemplated taking their own lives, because sometimes just asking them gives a truthful answer, and we shouldn't hide away from actually asking it. I found that in my own practice and out in community, by asking patients whom you don't really think are as depressed, you ask them the question if they thought about harming themselves, and can be very surprised by the answer. So it's a really important question to ask. And thinking about any comorbid psychiatric and medical illnesses, any personal family history of mood disorder, that's an important one. We've already talked about current medications, allergies, substance use, current stresses and life situation, and who knows. At the moment, we're all having different stresses due to the coronavirus and the lockdown, and the life situation that's happening for these people. Talking to my own family who are older, who may not be depressed, one of the things they've said that coronavirus has really confronted is the fact they're aging. They're in populations now, they seem to be in the vulnerable because you're over 70. A lot of our older, very healthy, fit and active older population that are not frail have found themselves being talked about as if they're a vulnerable group, and they found that quite difficult. And talking to some colleagues and friends of that age, they've said they actually find it quite debilitating, and it makes them feel differently, and mentally makes them feel unwell in terms of thinking of themselves as being vulnerable. So I think we shouldn't forget that. But assessing the level of function, just like we do generally, thinking about support systems and reviewing the results from our the AMT4 or mini mental health state exam and other cognitive functions, and just reviewing the collateral information. So everything that you do. But in relation to anxiety, asking somebody how long have they felt this anxious or low mood, where do they feel it in their body, what makes it worse? On a scale of 0 to 10, how bad is it at its worst, 10 being the very worst? Do you feel guilty when you need help? What would you do if someone you cared about asked for help? And the British Geriatric Society suggests that we routinely explore anxiety in our older patients. Out in the community, we use a generalised anxiety disorder, GAD-7, and it's asking the person over the last 2 weeks, how often have you been bothered by the following problems? Feeling nervous, anxious or on edge, not being able to stop or control their worrying too much, trouble relaxing or being so restless it's hard to sit still, becoming more easily annoyed or irritable, being afraid that something awful might happen. So if they don't feel that at all, they get a 0. If they feel it nearly every day in the last 2 weeks, they get a 3. And then the GAD-7 are added up. And as you can see, if they feel them, if they've got 0 to 5, a score of 0 to 5, they're mildly perhaps anxious, 6 to 10, moderate, 11 to 15, moderately severe. And if they get over 15 to 21, they're very severely anxious. And the other thing we should remember is GAD-7 will show us anxiety. So if you think someone's depressed, this can help you to see that they're also anxious. And equally, we should be looking for depression. So with the PHQ-9, we again asked them over the last 2 weeks, how often have you felt that you had little pleasure, an interest in doing something, having trouble falling asleep or sleeping too much, feeling tired or having little energy, poor appetite, overeating. And again, they get a score with, is it nearly every day or not at all or several days, feeling bad about yourself. That's a good one, I think. Feeling bad about yourself, or are you a failure, or let yourself down, or family down? Because asking that question can sometimes lead you to be able to ask that final question about, do you ever feel that you would be better off dead, or do you think about hurting yourself in some way? The PHQ-9, when you first start using it, can feel quite awkward. But as you get more comfortable asking the questions, what you do find is people, I personally have found older people, when you ask these questions, will be quite frank and tell you the truth. And you may not see it by looking at them. If you're in the community, it can be quite difficult anyway at the moment, because if you're not visiting people as much and you're relying on telephone consultation, trying to pick up these cues can be quite difficult. So the PHQ-9 is of use with GAD-7 in the community, but equally it's useful in the hospital. But in the hospital, there is a geriatric depression scale that is recommended by the British Geriatric Society, and they say over the past week, are you basically satisfied with your life? You dropped many of your activities and interests, and I mean, at the moment, lots of people have had to, whether they've wanted to. But do you feel your life is empty? Do you get bored? Are you good spirits? Are you afraid something's going to happen? So it asks a series of questions, and then it depends on whether you answer yes or no, and it depends on the questions. If you answer yes to questions 2, 3, 4, 6, 8, 9, 10, 12, 14, and 15, or a no response to questions 1, 5, 7, 11, and 13, that's indicative of depression. And so we should be routinely asking our patients and assessing for anxiety and depression. Do you do that in your practice? It's probably worth you thinking about how much you've built this into you. Those of us that work in physical health, how much have we built that in to our assessment of our older, frail patients? If we haven't built it in, can we start thinking about it? Over to you again, Vicky. Talk about bipolar.
So just a quick sort of word about bipolar really. New onset of bipolar or mania, so the elevated mood, overactivity, sleeplessness, irritability and excessive spending, or indeed confusion, is much less common in older age. Usually people are diagnosed when they're much younger. But if older people present with those symptoms of mania, then there should be a strong suspicion that there may be a physical cause for this, and that would need to be investigated in the usual way. So moving on to psychotic disorders. Again, a patient presenting with psychosis could be suffering from a long-standing psychotic illness, for example, a chronic schizophrenia or delusional disorder, or even a mood disorder, commonly psychotic depression, or an early dementia. But as in all psychiatric disorders, physical cause, especially delirium, and medication side effects need to be ruled out. And now I've definitely seen an increase in psychotic features in delirium during COVID. Also, both in COVID positive and negative patients, there seems to be a strange presentation of psychosis in delirium for our COVID patients. And I'm not sure if across the country that's been the same, but I think there'll be lots of research that will be very interesting coming out of that.
Yeah, and just on the back of that, I'd agree with that. There's some and it's not just related. So there is a steroid psychosis that can occur. This seems to be separate, wouldn't you agree, Vicky, to any steroid psychosis? For those of you that are thinking, people who are having dexamethasone, that they're more at risk of psychosis. We haven't seen that, and I've certainly seen a sort of psychotic element to those who are presenting with COVID-19, who are florally presenting, for want of a better word, with delirium. They seem to have more of an element of a psychosis during this time that I haven't seen before. So yeah, it'd be very interesting to see what comes out in time going on, and whether that's because people are more isolated. I don't know, but I agree with you. It seems to seem a bit more of that psychotic element in the delirium that I'm seeing.
Yeah.
Sorry, did you want to move?
That's all right. Moving on to dementia now. So we know that finding early cases of Alzheimer's allows the consideration of both pharmacological and non-pharmacological intervention. And it's really important that when somebody gets admitted into an acute hospital, that either we know that they have a confirmed diagnosis or not, because that may well lead us down a different treatment path and medications that we might use. But also, if there's been a patient who you know has a diagnosis of dementia, but there's been an acute change in their presentation, then it must be investigated for a physical cause and not just written off that this is a progression in their dementia. It may well be, but actually we need to rule out those other things first. That is a big bugbear of mine in an acute hospital. But early interventions by either a frailty team or a dementia nurse will help with the management of those patients. And we've certainly seen a number of patients who have an established diagnosis of dementia coming in more of a distressed state, because that the community mental health teams are not able to go out and routinely visit and support the carers, so they have no other option but then to come to ED as a kind of safe place, but also for us to have a look at, what is going on and what other support do they need.
Yeah, and on that note, sorry, I was just going to say, I was reflecting about this and how carers at the moment might feel an additional burden. And I wonder how able we feel we can support carers during this difficult period where they're not seeing perhaps the same people coming in, or nor indeed perhaps want people coming in, but helping them to recognise when their loved one is becoming different in the way that they behave to their normal, and therefore alerting us when they're getting early signs of delirium. Because what I'm seeing is they're feeling very isolated, the carers, and they don't know, certainly in GP practice, they're not calling us because they don't think we can do anything. Whereas if we could enable them to be empowered to call us when they have a little bit of concerns, because they do feel, well, GP appointments aren't happening, so what's the point in calling? And I've certainly found that last week.
Yeah,
Sorry,
most most certainly had an increase in admissions to the acute hospital for those very reasons, which normally wouldn't have got through the door. So a quick word on how to manage agitation in dementia. I think the best thing to do is avoid medication where you possibly can. But if you do need to go down a medication route because somebody is in such distress, and we're managing that person's distress, not the staff's distress, we need to think about using one drug at a time. So then we don't know which one's working if we're using multiple drugs, but also titrate the medication slowly. For agitation in dementia, risperidone is the licensed drug, but again, go low and go slow. But also think about the risk and benefit of stroke or also sudden death, as we know in antipsychotics. The other drugs to kind of consider is your patient depressed? Just because they have dementia doesn't mean that they won't be depressed. They may well be. So with an SSRI or something like trazodone, if people are not sleeping, going to be of benefit. We've also got the anti-dementia medications, and particularly thinking about memantine if there is some behavioural disturbance. We know we should avoid benzodiazepines, so your diazepams and your lorazepams, because it can have the opposite desired effect for patients with dementia. But actually, if you need to do that, again, go low and go slow. Next slide, please. So just a really quick word about the Mental Capacity Act versus the Mental Health Act. If we're talking about patients' level of distress, if they're in our acute hospital environment, does the patient have capacity to consent to their care and treatment? If they don't, then they need to be on a doles in the very least. And I still have conversations with staff across the hospital saying, well, they're not trying to leave. But it's not just about people not trying to leave, it's about do they have capacity to consent to their care and treatment. The other thing to consider is the patient a risk to themselves or others? And if they are, then we need to think seriously about whether this now tips into the balance of a Mental Health Act assessment as opposed to being cared and treated under the MCA. So, and which is the least restrictive way of helping to manage this patient. So all of those things, for any patient who you think may have a mental illness, those are the questions that we need to be thinking about. Next slide, please. I've included this slide because at the very top there in the first box, we're thinking about a comprehensive geriatric assessment to include mental health, but often this component of the CGA is simply overlooked or lists diagnosis that a patient might have. So just to kind of really reiterate, if we are going to do a comprehensive geriatric assessment on our patients, we need to complete a full and holistic assessment where the mental health needs must be completed. Next slide, please. So where I work, I'm not part of the psychiatric liaison team, but I will often see referrals that they've referred to me and I will refer to them, or sometimes we will do some joint working, but I'm often the link between acute services and community services via psych liaison. So I work very closely with them, as well as our local community mental health teams and our approved mental health practitioners. If I believe that somebody might now need assessment under the Mental Health Act, they will accept my assessment very often.
And I do think that's really important, Vicky. You've made a really good point, because there's several hospitals that I link with and visit where those teams are completely separate from any frailty team, and in order to refer can be quite problematic, particularly at this time of COVID. So I think that collaborative working that you propose, that you have actually, is so important, and anybody that wants to know more, I would urge you to get in contact with Vicky to find out how they have ever set up and how that's working. So thanks for that, Vicky.
That's all right. So the last sort of slide that I have, the key messages really is about within old age psychiatry, we're trained to adopt a holistic approach and practice within a biopsychosocial model. So we should focus not only on what's the matter with the patient, but more importantly, what matters to the people and the patients that we're serving. So please just remember that mental health is as important as physical health, and we just need to keep talking about it. Thank you, Mandy.
Yeah, no, I so agree with that. So what can we do? And the recommendations from the Royal College of Psychiatrists last month really looked at commissioners and service providers and how they should be thinking about that, and about having more research about the impact of mental health illnesses on frailty, as well as looking at the correlation between serious mental illness and the risks of developing frailty, so that we make sure that we give best evidence-based care to support people. Old age psychiatrists are trained to adopt a holistic approach, and as Vicky's just said about nurses as well, and they focus on what's important, and they're saying that's what should happen and what we should be constantly thinking about. There's specific expertise available for us, and why are we using our Royal College of Psychiatrists more? What I really wanted to also think about is we've talked about mental health, ill health and frailty, and I talked a little bit about how we can support each other and recognise with each other actually the manifestations of us all becoming perhaps anxious, depressed following COVID as we move into recovery. Psychological first aid is a term that's more and more coming into our use. I know that some hospitals have psychological first aid. Mental health practitioners have moved into the acute hospital, provided wellness areas for staff to spend time in. But as we think about psychological first aid, last month the Royal, what's their names? I've lost who they are. There's a group internationally, Red Cross, the International Red Cross, actually talked about psychological first aid and the importance. And what we should do is accept that people will feel angry, frustrated, anxious, and all of us, staff and patients, will feel that. And we should accept those feelings. We should recognise that they might manifest themselves more commonly now as we're moving forward, having had COVID-19 amongst us. We should think about limiting the worry time, and I certainly have done this, about, you know, how often are we going to worry about what we can't control and our loss of control. And if you perhaps just allow yourself 1 or 2 times a day to do that worrying, perhaps half an hour in the afternoon, or if you have worrying thoughts at other times of the day and night, tell yourself that you're not going to think about that now, you'll stick it in the worry time. And ask people, your colleagues and patients, what do they usually do if they feel like this? How do they usually cope with difficult situations? And can that be applied now? A bit difficult if what you normally do is socialise in a time when people have been locked down. Again, limiting news and media time, perhaps twice daily, not keeping the TV on all day to listen to the news and the sort of negativity that might be in there. Keeping to daily routines. I certainly find that with my patients, that where they're particularly anxious and have a really anxious component, getting them to stick to a daily routine and set goals and keeping active, even if they're, you know, those that are isolated and they're screened, keeping away from other people, they can still have a daily routine where they might wake up early and they go for a little walk when nobody else is around, or late in the evening when no one else is around. And they and also using some of the technologies that they can keep socially close but physically distant, so they can still be close to their family by the use of some of the social media abilities. Using calming techniques, breathing and relaxation exercises, thinking about how to breathe more deeply. There was a great thing on the telly the other day where they were teaching people to breathe, hold their breath for short times. And if someone's very anxious, getting them to think about the way they're breathing and the in-breath as well as the out-breath can help them just to bring that down. Don't forget to look for humour. I think in the healthcare service we look for humour rather a bit too much, and outsiders looking in can think we're a bit sick. But smiling and laughing can provide relief from anxiety and frustration. So the psychological first aid is really important, and we shouldn't forget it for not just our patients, but for each other. If you haven't already linked with your mental health colleagues, and particularly those mental health colleagues who work in universities at the moment, where they can't go back into the university, can they help you within your trust in setting up these wellness areas? They've certainly done that in a few trusts near where I work, in supporting the maintenance of mental well-being amongst staff. So we haven't got any more to add to that. And thank you all for listening. Vicky and I are available for any questions. And if you've got any questions, please do think, or if you've got any comments or anything that you'd like to add, or anything you'd like to see in future webinars around mental ill health. We are planning a couple more in which colleagues from Newcastle will come and talk about what they've done and mental health and their responses there. But if you've got anything to add, please do email us, and thank you very much for listening. Do you want to add anything, Vicky?
No, just thank you very much for inviting me onto the talk.
Well, thank you. Well, thank you, everybody, and we'll say goodbye. Thank you.